Good morning, everybody. Thank you very much for the kind invite and organizing um, the teaching sessions. Uh, it, Today's topic is around the imaging of acute aortic syndromes from the radiology imaging perspective. And when it comes to acute aortic syndrome, um, the main focus would be around the CT that plays the main role in imaging of acute aortic syndromes. So the focus today in this presentation is going to be around the role of CT in imaging of acute aortic syndromes. I'll try to go through some terminology and what is included under this umbrella of pathologies. There is a long list. However, there are three main conditions that fall under this umbrella of acute aortic syndromes, which would be the aortic dissection, intramural hematoma, or penetrating aortic ulcer. There are other topics or entities that might fall under the umbrella of acute aortic syndrome. However, those are the three major topics. And this session, possibly for the sake of time, I'll try to focus on the three major entities. How, or some in brief, some of the techniques in CT, when to request this protocol and when to avoid that protocol. Um, some hints about the differential or the crucial differential diagnosis of acute aortic syndromes. Possibly it wouldn't be time to cover the other entities, so I'll try to start and go through the three major entities that are frequently encountered in the radiology suites. We understand sometimes there are things that might lead to the rupture or might lead to the dissection or the hematoma. Sometimes it's a disease that is, or a defect that is in the background. For example, some pathologies related to connective tissue disorders that causes the wall weakening, or that the muscle of the aorta gets thinned out. And under the stress, we understand that the pressure in the aorta is 120/80, or under some shear stress, that the direction and the pressure, wear and tear along this wall. In one aspect, it is weakened by the genetic disorder, and it's under wear and tear. So it's a process that might lead to a rupture or aneurysmal formation and then a dissection. Sometimes it's an aortic valve disease, for example, the bicuspid aortic valve, which it changes the direction of the flow, and changing the direction makes the flow, instead of being streamlined, it becomes helical flow. And the helical flow would lead to some pressure points or shear stress at certain points in the ascending thoracic aorta, and it starts to dilate. For example, in this image, we could see that the aortic root is markedly dilated. And that is a bicuspid aortic valve. So you can see here, maybe it's a small picture, but that would be the left atrium, that would be the right atrium. So that is the non-coronary sinus. We know that the aortic valve should be tricuspid, but in this case, the right and the left coronary cusps are fused together. And that leads to the helical flow, and the helical flow starts putting pressure at certain points in the aorta, dilating the aorta, and the wall becomes more and more weak, and then prone and liable to be dissected. Also, sometimes it's related to age, or a certain gender. A systemic disease in the background, also sometimes like hypertension or severe atherosclerotic changes. Those systemic diseases also might lead to dissection or hematoma, or a penetrating ulcer that is impacting the intima of the or the integrity of the aorta. In general, the three major entities might present by severe chest pain. Sometimes the location of this chest pain would tell you where exactly is the segment of the aortic segment that's being affected. If it's neck and jaw, or in this it's neck and reflected to the jaw, then it might reflect that this is in the ascending. And from anatomy, we know that the descending thoracic aorta is in the posterior mediastinum. and then posterior retroperitoneal, which means that sometimes the pain will be in the back, similar to the pancreas, or those retroperitoneal organs. So the pain will be reflected in the back. It's sometimes in severe conditions or in severe cases, it might present by a shock or a hypotension or severe heart failure signs. Um, the modality of choice in acute aortic imaging would be, or acute aortic syndromes, is the CT, and that typically involves some technical aspects. For example, if we are on call and there is a query dissection, usually we would ask for a CT, but the CT, just in brief, there are two types of, for example, of performing the scan and exposing the patient to irradiation. We understand that the heart is in a moving environment, which is the chest, and the diaphragm is moving, and it is moving by itself. Respiratory wise, we could overcome the respiratory motions by asking the patient if they are conscious, breathe in, breathe out, and stop for just a few seconds in order to make the acquisition. But the heart motion itself, we cannot stop it. And if we do not overcome that motion, that would lead to something called pulsation artifacts. The pulsation coming from the heart propagates inside the aorta, at least, especially in the root and the ascending thoracic aorta. So what does it mean, a non-gated CT or a non-gated ECG gated study? This means that the patient will lie on, be put on the table. The exposure will just run as soon as all the parameters, kV, milliamperes, are being adjusted, and then the exposure might be in systole, might be in diastole, irrespective to the cardiac cycle, and that might lead to later on to a pulsating artifact. However, on the other side, ECG gated means that it is respecting the cardiac cycle. So it checks where exactly is the RR intervals. And then it will provide the exposure in order to provide the exposure at certain time point of the cardiac cycle, where there is the least motion, where is the least pulsation artifact, in order to provide good quality images. For example, this one, sometimes the question comes, query aortic root dissection. And because the scan was non-gated, see the pulsation artifact. So the reply and the report was query aortic dissection. That is non-diagnostic information. And, and it just would be a kind of unnecessary exposure for the patients. So if the dissection is around the aortic root in the ascending thoracic aorta, then it is advisable to request the gated study and avoid the non-gated study. And that, on the opposite, that is an example of a gated study where we can see clearly the aortic wall. We can see clearly where is the dissection. We can see the true lumen and the false lumen. We could see the coronary, whether there is any involvement of the coronary ostia. That would be, of course, on it's. There are some points to consider here that would be, of course, on the expense that is going to provide higher radiation doses to the patient. However, in acute emergencies, we have to weigh the risk and the benefits out of providing or giving some more radiation, but the benefits are very high that we will have a definite diagnosis, or whether there is involvement of crucial arteries, for example, the coronary arteries. Considering it's not in every trust that they are capable or the expertise of doing ECG gated studies, maybe sometimes in tertiary centers, often get receive a request to repeat a scan that have been performed just the night before, because it was performed in another trust where there is a non-gated or ECG gated CT scans. So that is something also point to consider. Maybe to ask the radiology team, do you perform ECG gated studies or not before exposing the patient? Some authors would do like a triple phase, so 3 runs, 3 different acquisitions at 3 different time points. Each time point or each scan provides or serve a certain function in order to reach the diagnosis and at the end. Um, One would be maybe the non-contrast study, followed by an arterial phase, which is usually maybe after 20, 30 seconds, and then the delayed, which is around 60 to 90 seconds from the contrast injection. And each run plays or serve a certain role. For example, the non-contrast, some authors would run the non-contrast study in order to see the hematoma. For example, in this arterial wall, we could see that this mural or this aortic calcification is being displaced inwards, and there is hyperdensity that is behind it. So that is a hematoma that is displacing this calcification. Similarly, here, if just try. I'm not sure if the image is very clear, but there is two different densities, one in the central lumen and one as a crescent around it here. So that is also a hematoma. Sometimes it's useful to detect hemopericardium and hemothorax, because on non-contrast studies, we could measure the densities. So we could apply a ROI that would tell us what is the density at that area. And we know from 0 to 20, for example, Hounsfield units, which is the density unit in CT, that would tell us that this is a serous fluid. If it's between around 20 to 40 ounces per unit, we would say that is an exudate, so it might be a pus infection. If it's higher than the 50 hematomas, that would tell you that there is a blood component in this area. Above 80, that might be an active bleeding. That is the same image after giving the contrast, and we could see here that is the density that was seen on the non-contrast, and similarly that was the crescent density or the hematoma in this scan. On the other side, the arterial phase would provide a clear diagnosis. It can detect, of course, the flaps in dissections, and similar to the previous case, it detected the hematoma from the contrasted or the patent lumen. Also, the arterial phase is necessary to check for coronary involvements or cranial vessel involvement, abdominal branches, for example, the superior mesenteric artery, in order to detect for any complications, for instance, bowel ischemia. On the other side, sometimes delayed images are necessary. That is a normal scan of the kidneys. This scan is an arterial phase, but still it's just the delayed some organs is necessary to see the contrast excretion. For example, here we could see this kidney is not contrasted compared to the left kidney, which is well opacified. In cases of dissection, sometimes there is a slow flow phenomenon. So that sometimes the arterial phase might miss. It's too fast for perfusion of certain organs. This is where a venous and delayed phases would come in order to provide more insight about the organ perfusions. The three entities, mainly aortic dissection, intramural hematomas, and penetrating ulcers. So we could see from the images, aortic dissection, that is a tear that took place through the intima, and then it acts or provides or causes a kind of a new channel or a new lumen within the wall of the aorta. So that would be the true lumen, and then through this entry or through this dissection is going to be a new false lumen within the wall of the aorta. Later on, it will be filled with blood, and then there would going to be two parallel lumens, the aortic true lumen and the aortic false lumen. Hematoma means that there is a blood or a contained hemorrhage from the vasa vasorum of the aortic wall that is contained within the wall, and there is no tear, there is no flap, in order to differentiate a hematoma from aortic dissection. Penetrating ulcer, sometimes it's on the top of severe atherosclerotic changes. We could see this yellow. This means there is an unhealthy intima, showing atherosclerotic changes, irregularities, so it's not smooth anymore, similar to the other cases. And those irregularities usually get ulcerated. Sometimes they rupture and dislodge or causes some emboli. And then sometimes this ulcer just erodes in the aortic wall, go outside through the intima and go outside the contour, as we will see in the the next slides the different entities and what are the imaging findings that we can see. So let's start with the dissection. And again, the dissection is going to be an entry or a tear in the intima. That is the true lumen. So something has caused all weakness on a background of systemic disease or a connective tissue disorder, and that led to that the blood is flowing through this entry or through this defect into the false lumen, and the false lumen starts because it's a low pressure, so it starts to develop and gets bigger and bigger to the extent that in most of the cases it is bigger than the true lumen. Acute means that it's within the first 2 weeks. CT, or before going to the CT, for example, that is cases where X-ray might help. This patient already had the treatment, but it's just to show the aneurysmal dilatation sometimes could be detected on X-rays, and sometimes the calcification also, if there is a displacement of the aortic knuckle calcification on X-ray, so it might give you a hint that it might be a hematoma or a dissection is taking place. CT will provide, if there is a high sensitivity, high specificity in the CT diagnosis of dissections. It can see the flap, it can see the entries, it can measure the true and false lumens. Of course, it can detect the extension and would classify. And why is it important to classify? Because the classification would decide the management later on. It can check on complications. So on one side, of course, after providing the diagnosis and detecting the flap, it can tell you whether this dissection flap, is it in the ascending, which is type A, or is it in the descending, which is type B, or now there have been recently a new diagnosis of non-A, non-B diagnosis of dissections. Those are the dissections that are in the arch, whether they are extending or not extending to the ascending or the descending, but those are the new, or it's recently came in the classification of dissections. So CT can provide the classification and diagnosis accordingly. Usually then, if it's type A, then the surgical management or intervention is required. Type B, it might be medical under discussion. If there are complications, then it might be for an elective after MDTs, it might be for an elective endovascular repair at a later point. So CT first will provide high sensitivity to provide the diagnosis. Two, it will classify what type of dissection, is it A or B, which will decide the management later on. In most of the cases, we could see that the false lumen is going to be bigger than the true lumen because it's lower in pressure. So most of the blood will go. Sometimes it's thrombose, and then it would just push the true lumen. The dissection in the descending thoracic aorta sometimes is dynamic process. So along the time, with proper management, the true lumen sometimes restore some of its diameter, and along the time, sometimes it gets bigger and bigger. However, as we mentioned, if the dissection is in the ascending, it's kind of an emergency that requires the theater or the surgical approach. CT also can provide extension, whether the how far is it going down. So we can see here, for example, that is the true lumen, the small one, and all of that around it is the false lumen. The true lumen usually is more hyperdense and smaller in size, and CT can give you a bigger picture. So we could scan the entire aorta, and also if we wish, we could add also the cranial vessels, so we can see extensions, cranial, and coded how far this description or the morphology of that dissection. Also precise measurements. For instance, sometimes these patients, as we mentioned in type B, will be on medical and elective management, which means that they require multiple follow-ups. So CT can provide solid numbers, accurate measurements of the false lumen, of the true lumen, the ratio between the false and the true lumen. Sometimes some organs are being supplied through an artery, for example, renal artery sometimes arise from the false lumen. So they keep perfusing the false lumen because it's supplying some organs. However, change and sometimes they are kind of a dynamic process in the dissection, the descending thoracic aorta. So it is important across the time to keep eye on what is the diameter of the false lumen, diameter of the entire aortic sac, and the ratio between the false and the true lumen. And also to keep eye on if there is any new developing thrombosis developing in the false lumen. Sometimes it increases the endotension. Sometimes if the thrombosis increases in the false lumen, that would increase the pressure on the true lumen. So it might cause narrowing of the true lumen. So CT during the follow-ups, again, could provide a clear and a solid report. Also, it could provide in very emergency and urgent cases where we could see the flap in this aortic dissection went back inside the LVOT. So that is the left ventricle, left atrium, and that is the aorta, and it's called windsock. It's a very rare entity, but it could happen that the dissection extends in the coronaries, or it could go back into the LVOT, and that is obstructing the outflow tract, which means it's obstructing the outflow of the blood, obstructing the stroke volume of that ventricle. I don't have the video of the echo, but the echo video was it shows this flap moving in and out throughout the cardiac phase. That was an emergency. That patient was taken quickly to the theater. As we mentioned, sometimes it extends to the neck vessels. Those are the four neck vessels. We could see left subclavian artery, left common carotid, right common carotid, and we could see on the right subclavian the dissection flap is extending from the aortic arch. It extended up to the subclavian artery. Sometimes it extends, of course, to the carotids or to the abdominal branches. So, for example, in this case, it extends to the superior mesenteric artery, causing a hematoma. We cannot see the artery because it is occluded, or it is occluding the hematoma, is occluding the superior mesenteric artery, or might affect one of the renal vessels. Again, if we compare the right to the left, we could see that the left is well opacified, which means well perfused, but the right is not perfused. Cases where sometimes it extends up to the common carotid. It might cause, of course, in the brain, like strokes. See in this CT brain, those dark areas represents those are kind of strokes. So it might be either a dislodged thrombus, or that is the dissection extended into one of the common carotids and affected the perfusion of the brain. Also, abdominal organs that might be affected. For example, in this case, there is cortical necrosis, which is caused by severe hypotension, non-contrast, and then the arterial phase, there is no any perfusion to the kidneys. And in the delayed phase, we could see this some cortical enhancement, and that is typical for acute cortical necrosis that sometimes happens with severe hypotension and shock that sometimes occurs in dissection of the ascending thoracic aorta. The second, which is the intramyocardial hematoma, as we said, there is a contained hematoma or a hemorrhage from the vasa vasorum within the wall. However, there is no flap and there is no entry point, there is no tear in order to differentiate it from the dissection. It is sometimes spontaneous, sometimes it happens kind of iatrogenic during a surgery or an intervention, because it's still sometimes it's not known what happened with this intramural hematomas. To differentiate it from a thrombosed dissection false lumen, sometimes the follow-up would reveal a hematoma would decrease, but if there is a flap, then it will start to appear in the follow-ups. So the presence of a flap would differentiate it from the dissection and from the intramural hematoma. The non-contrast study, if you remember the protocols, the non-contrast study are very useful in intramural hematoma detection. For example, in this case, there is a non-contrast. We could see the hyperdensity that is within the wall of the aorta. One of the signs is that the atherosclerotic calcification should be in the periphery, should be mural, but in this image, we could see that the hematoma is displacing the calcification inwards, which is a sign that could detect um, um, an intramural hematoma. For example, those two cases, the first case where the video should be playing, yeah. Effusion, again, we could see the crescent or the intramural hematoma that is extending almost throughout the entire aorta. If we make it play one more time, see it here, here, all around the mural hematoma, the left lateral wall. That is a second case. See here on the chest X-ray, that is an example of, we could see the calcification and the aortic knuckle is being displaced inwards. So that is the aortic knuckle. We could see the calcification here. It should be peripheral, should be a mural, but in this case have been displaced inwards, which was kind of course, suggested that is something is happening. And that is an example of where, how could we measure the density of the wall of the aorta. In this case, that was 50 something. That presents or kind of highly suggestive of an intramural on the non-contrast study. So we proceeded with the contrast arterial phase, and we can see the thickening of the wall of the aorta. That is just a normal case, just to compare how thick is the arterial wall or the aortic wall in cases of hematomas compared to a smooth wall is maybe 1 millimeter, if not less, in normal CT scans. Again, that is just to show how maybe there is zooming on the density here that came 55. If you remember, we around 50 to 80, that is represents kind of a clotted blood or a hematoma. So the CT can measure the densities in the hematomas, or if there is accompanied or associated effusions, whether pericardial or pleural effusion. Sometimes both of them are present. I think this is the first video. And then maybe later on the follow-up might show that it's not only hematoma, but for example, in this case, I'll just make it run. Yeah. So in the follow-up, there is a dissection flap, although at the beginning it was thought that it's just a mural hematoma. So sometimes it's kind of complex entities where both of them are present in the same scan, and the follow-ups would reveal the flap of the dissection. Penetrating ulcers. Usually it happens, or usually there is in the background severe atherosclerotic changes, sometimes in elderly patients, and that would lead to that the ulcer would start eroding into the intima, and then goes outside or beyond the contour of the aorta. For example, in this case, we could see that is the descending thoracic aorta, and we could see those atheromas. So that is a healthy wall, the left lateral wall, but we could see the posterior wall is just kind of irregular, showing this hypodensities or opacity that is making the contour is irregular, and because they are unhealthy, so under pressure, this wall is weak, so the blood and the pressure starts penetrating inside the intima because it's unhealthy and it's a weak wall. Sometimes it's small in descending thoracic aorta, where possibly the management would be a follow-up, but sometimes they are quite big, and they might rupture or cause hematomas in the mediastinum. For example, in this case, that is the ascending, and that is the descending thoracic aorta. CT can provide measurements in case that the team decides a follow-up. Again, we could measure the depth, we could measure the maximum diameter, measure the neck. That would help it for deciding a follow-up or an immediate intervention. of course, sometimes it occurs in the ascending thoracic aorta, so that would be a sagittal view. We could see that is the descending aortic arch going back into the heart, that is the ascending, and it shows a big ulcer. That is the reconstruction, and we see that goes beyond the aortic contour. So the ulcer have been penetrating throughout the aortic wall. It is showing this unhealthy or diseased wall around the ulcer, and that is high risk that it might rupture at a certain point. Again, there is another example of a penetrating ulcer in the aortic arch. There might have been kind of a hemorrhage from this ulcer that led to thick, irregular granulation tissue around the wall, or fibrosis and scarring around the wall. So it's a repeat of the slide. So why CT? To tell that CT is available in most of the trusts or most of the hospitals fast, high sensitivity and specificity, it could provide imaging of the aorta, defining the diagnosis, and risk stratify the patient for the follow-ups, and also can go beyond the aorta as an organ. It could go for multi-system organs. It can provide, of course, a high resolution and 3D reconstructions, as we saw that would help, of course, the surgeons later on to understand those images in reconstruction. They are in space, so we could show the anatomical relationships to the sternum, and also we could see the complications. We could measure whether there is a hemothorax, or there is a sign of hemopericardium, there is tamponading associated with those cases. Also, CT can provide insights. There are some other differential diagnosis that might present itself in a way more or less similar to acute aortic syndromes. For example, if there is acute coronary syndrome, we saw on the gated study, for example, in this case, that was 28 years, coming with a chest pain. It was query aortic dissection, but later on the dissection was in the coronary. It wasn't in the ascending. So we could see that is the ascending thoracic aorta giving the left main, and the left main here in this case is trifurcating. So it's giving the left anterior descending, ramus intermediate, that is the circumflex. And at the distal left main, ostium of the left anterior descending, we could see this opacity. So that is a normal healthy artery, but we could see this irregularity here. That is most likely in an acute setting that presents a hematoma on top of dissection, but this time is in the coronary. And sometimes they heal by themselves. So this patient was, for example, asked for a follow-up in 3 months. So CT have differentiated between that this is not a dissection, the ascending thoracic aorta, sending the patient to a theater. Now that is in the coronary, and we will wait and see. The other entity might be pulmonary emboli. Sometimes presents itself in a way confusing with a dissection. But for example, in this case, this patient had a large dissection and a hematoma from the aortic arch, but the patient, we could see that is the superior vena cava draining to the right atrium, and see this filling defect. That was a large thrombus inside the superior vena cava, and those thrombi in the brachiocephalic superior vena cava or in the right side, sometimes they would emboli to the lungs. That is the same case, and there have been pulmonary emboli. So the CT was diagnosing the dissection, and also that this patient had filling defects in the superior vena cava and pulmonary emboli. Later on, of course, the follow-ups, CT again would give you, for example, this patient was post-operative, but unlucky, the patient, well, it showed a renal tumor. So, of course, that has changed the plan and the management later on for this patient. Sometimes it could differentiate between the mimics, so that is the left ventricle, aortic valve, and that would be the aorta. Sometimes we would see, especially in bicuspid aortic valve, we could see this plastic bands coming from the aortic valve toward the ascending thoracic aortic wall. they are not dissection. This patient was diagnosed by dissection in echo. However, CT has shown that this is just a dysplastic band, and the patient was not sent to theater. After receiving the proper management, sometimes CT could detect any complication. For example, this patient had a stent, an aortic root, and ascending thoracic aorta replacement. We could see here those are the points of the anastomosis of the new aorta. So we could provide insights about complications like endo leaks around those stents, the patency of those stents. Is there any leak around the anastomosis? Is there any kinks, or there is any complications? For example, there is a big ulcer in this case coming out from the descending thoracic aorta. And thank you very much if there is any questions.